Hello, everyone. And thank you very much to the organizers for the invitation to come speak with you here today at this really wonderful meeting. It's great to see so many people come out to hear more about the research that we're all doing. And so I'm going to be talking about what I think is a very exciting new area of immune therapy for cancer, particularly for the hematologic cancers, the blood and bone marrow cancers. And this is called CAR T-cell therapy. And so first I'll give a little bit of background about the immune system and cellular therapy. Then I'll explain what a CAR is and how we manufacture CAR T-cells. I'll go through some of the clinical results so far in some of the cancers where CAR T-cells are showing the most promise, acute lymphoblastic leukemia, ALL, non-Hodgkin's lymphoma, and multiple myeloma. I'll talk about some of the side effects that we can expect with CAR T-cells, and then talk about the challenges with this therapy and where we're going from here. And so first, in order to understand a little bit about immune therapy, we need to know a little bit about the immune system. And so all of the cells of the immune system are developed in the bone marrow initially, and they come from this initial hematopoietic stem cell, where all of the blood cells come from, including the red blood cells, the platelets, and of course the white blood cells, which are infection-fighting cells, including granulocytes or neutrophils which fight fungus and bacteria, B cells, which we heard about, make antibodies which help protect us. They circulate through the blood and protect from viruses and bacteria, and now can be engineered to attack cancer. But the type I'll be talking about particularly are called T cells, and T cells are, again, part of our adaptive immune system. Their job is to recognize other cells that have become infected and try to eliminate those cells, and they come in different subtypes. But what we also have known for a long time is that T cells can also recognize malignant or cancerous cells. And this is an example of a T cell recognizing a melanoma, a skin cancer cell. And so the question arises, if we all have T cells that are able to recognize cancer, then why does the cancer still grow? How is it that the T cells can't eliminate the cancer? And the reason, unfortunately, is that over time, the cancer cells can learn to evade these T cells. They can alter their surface landscape so that T cells can't recognize them anymore. Or they can secrete factors that end up suppressing the T cells, and the T cells become dysfunctional or exhausted, and they're not able to work anymore. And so the revolution in immune therapy for cancer has really focused on two main areas trying to overcome this problem with the T cell function in the patients. And one of them is trying to give medicines that can reinvigorate or activate the T cells within the body. This is called checkpoint blockade, and Dr. Weber is going to talk about this in the next lecture. The other option is to take the cells out of the body and try to activate them in some way and change them so that they now regain their effectiveness, and then put them back into the patient. That's called cellular therapy, and that's what I'm going to be talking about. And so when we think about cellular therapies, there really are two broad categories of what I call autologous cellular therapies, meaning you're taking the cells from the patient and putting them back in. So they're actually your own immune system, your own immune cells attacking the cancer. And the first approach is what I call the non-gene modified approach. And this was really pioneered by Steve Rosenberg and colleagues at the National Institute of Health in Bethesda, Maryland. And what they did was actually take out surgically cancer from the patient and try to isolate what are called the TILs, tumor-infiltrating lymphocytes, the white blood cells that were already in there mixed in with the cancer but just weren't effective. And they would very painstakingly dissect out the tumor and get the white blood cells, try to activate them in vitro, in a petri dish, grow them, and then give them back to the patient. And this actually can work and was shown to be successful in a significant proportion of patients with melanoma, a type of skin cancer, as well as other solid tumors. But it's very laborious and painstaking, and not every patient has a cancer deposit that's amenable to this type of approach. And so the other main approach that's gone forward is called gene-modified T cells. And these can actually be isolated from the blood, so much easier to get a sample. And instead of just relying on the T cell's natural ability to recognize the tumor, they actually are modified by giving new genetic material that encodes for a new receptor that can recognize specifically the cancer cell. And the two main types are to put in a new T cell receptor or to put in a type of receptor called a CAR. And this is the one that's actually showing the most promise right now and the one that I'm going to be focusing on. So what is a CAR? CAR stands for chimeric antigen receptor. So you may remember from your Greek mythology, the chimera was a mythical creature that had the head of a lion, the body of a goat, and the tail of a serpent. And so it was a mishmash of these different animals. And a CAR, a chimeric antigen receptor, is a similar mishmash. It has the head of an antibody. And you remember we heard about antibodies earlier. They're very specific for one target on the surface of a cell. And you can pick any target that you want and create an antibody. So they have the head of an antibody, but they have the body and tail of a T cell receptor so that they're able to signal through the T cell and activate that cell to grow and divide and actually kill the cancer cell. And this concept is not new. This was actually first described in the late 1980s, early 1990s. So we've known about this idea of CARs for over 20 years. But what took a long time was to try to get this to actually work in patients. And there were several steps. The first was the development of better techniques to get the gene encoding the CAR into the T cells. And so with novel gene transfer techniques, we're able to get this CAR to be expressed in the T cells. And the one that's used the most is actually a lentiviral vector, and I'll explain in a moment about what that is. And the other thing that was very important was not that the CAR would just signal once, but actually be able to maintain its persistence in the cell and allow those cells to grow and last a long time. And that was the addition of these additional signaling domains called CD28 or 41BB. When this was added to the CAR receptor, it allowed the T cells to continue to grow and persist for long periods of time and make this a viable therapy. So how does this work? So the vector that's used to get into the T cell is called a lentivirus. This actually is the same type of virus as HIV. HIV is very good at infecting T cells, which gave the scientists the idea to use it. However, they've taken out all of the guts of the HIV, so it's no longer able to cause disease, but it's just used as a delivery vehicle to get the DNA encoding the CAR into the cell. And so what happens is the cells are taken out of the body and in vitro in a manufacturing facility. They're infected with the virus that encodes the CAR. The CAR is now produced within the cell, and the T cell now expresses the CAR on its surface so that it's able to recognize something different than what it recognized before. In this case, a molecule called CD19, which is expressed on a number of B cell cancers. And then you grow up these cells in large numbers, you infuse them back into the patient, it seeks out the cells, and it kills the tumor cell. And what's important about this is not only that it goes in and it has cytotoxicity, killing ability, but it also produces molecules called cytokines that can actually communicate with other immune cells in the body and activate those cells as well. And importantly, these T cells can persist for long periods of time in the patient. And so what you've really done is create a living drug that's given one time, but that lasts for months or even in some cases years to be able to provide surveillance against the cancer and potentially, hopefully, prevent it from coming back. And so how does this work in practice? And so a patient is identified who's a candidate for the therapy. They undergo something called leukapheresis, which is the way we collect the T cells. This is very similar to what you saw in the way we collect stem cells for a stem cell transplant. There's basically this machine. It looks like a dialysis machine. Blood goes out, they suck off the T cells, and blood goes back in. They're on the machine about 3 or 4 hours, and then the cells are done. Those cells are then sent to a manufacturing facility where they're activated to try to start the T cells to grow, and then they're infected with the virus that delivers the CAR to those T cells. And over the next 10 to 14 days, those cells are expanded to very large numbers. They're highly activated. They're then purified and frozen down for the patient, and then when it's time to administer them, the patient gets usually a couple of days of chemotherapy to briefly deplete their own white blood cells to make room for the CAR T cells to go in, and then the CARs are infused sort of like a blood transfusion. And this whole process takes about 3 to 4 weeks to manufacture and get the cells into the patient. And then you wait and see if the cells find the cancer and are able to eliminate it. And remarkably, this actually works. And so the first target that really showed a lot of promising activity was CD19. This is that marker that's expressed on the surface of B cells, and particularly B cell cancers like acute lymphoblastic leukemia, CLL, chronic lymphocytic leukemia, and a certain type of non-Hodgkin's lymphoma called diffuse large B cell lymphoma. And simultaneously in 2010, 2011, there were 4 different institutions, Memorial Sloan Kettering, our center at UPenn, the NIH, and Fred Hutch in Seattle, that reported on the first few patients that received CAR T cells and had dramatic resolution and decrease in their cancers. And these were patients who had really refractory disease that had exhausted other options. And so it really showed proof of principle that this could work. And what was amazing is that this can actually be durable. In fact, one of the first patients treated at Penn on one of the trials in 2010 still is in remission 9 years later and still has circulating CAR cells detectable in his bloodstream. Now, this also showed some very significant toxicities or side effects that were somewhat new. And so this also required a lot of work to try to manage those, and I'll talk about this in a moment, called cytokine release syndrome and neurotoxicity. But to give an example of sort of the excitement this was generating, I'm going to show you a brief video. This was the first pediatric patient that was treated on a CAR T-cell trial at Penn. She was a 7-year-old girl at the time in 2012 with refractory acute lymphoblastic leukemia. And there was a short video, about 3 minutes, that was made describing her experience. So let's see if this works.
Take one.
Is it hard for you to say those words, "We're trying to cure cancer"?
That's a really good question, and why it's hard to say we want to cure cancer. We do. And I think sometimes it's hard actually to think that you might actually succeed.
Patients that we're treating on this clinical trial have absolutely no other options left for them. These are patients who are unfortunately destined to die of their disease, and in a fairly short amount of time.
Emily Whitehead, 554.
So Emma is incredibly matter of fact about all of this stuff. This was a child who had had her leukemia come back twice. The parents were looking for a miracle.
What we've learned how to do is train the immune system to recognize and then kill tumor cells.
It's a procedure where we collect their T cells, and they are infected with a virus that will genetically change them so that they will now see and react against their leukemia cells.
And we actually use the HIV virus to do that.
So you're taking the HIV virus and infecting healthy cells with it to help kill cancer?
Yes. The virus has been engineered so that it can't cause disease anymore. But it still retains the ability to reprogram the immune system so that it will now attack cancer cells. We call those modified immune cells serial killer cells. Each infused cell can kill more than 1,000 different tumor cells.
But the reality is the dramatic responses of cancer to new treatments are very unusual. We need to make it clear when we talk to a family that it may not work. Emma was given her T-cell treatment, and within a few days, she was very sick. She had breathing difficulties, she had blood pressure difficulties. We knew that she could not have gotten any sicker without actually dying.
But then a remarkable thing happened. The T cells were growing, they were starting to fight the cancer.
Within hours, Emma's fever disappeared.
It was like the calm after the storm. The clouds went away, and she woke up, and there was no leukemia. When that child survived, it was, of course, an amazing event.
So it really was an amazing story, and I'll come back to Emily in a little bit. But she had acute lymphoblastic leukemia, which is one of the more common childhood cancers, and it's actually cured in over 80% of patients in children. In adults, we're less successful, but it requires intensive chemotherapy for years, in many cases a bone marrow transplant, and if the disease does not respond or it comes back, then it becomes very difficult to treat. There's very limited options. But ALL expresses this receptor, CD19, and so this was one of the first cancers where there were trials using CD19-directed CAR T cells. And again, 4 different centers initially published their data, small numbers in the beginning of both adults and children, but with really dramatic response rates. CR stands for complete remission, and you can see anywhere from 67% to 93% of these patients went into complete remission after getting these CAR T cells. Now, there was toxicity, and again, I'll come back to this, cytokine release syndrome and neurotoxicity, but this really was dramatic proof of principle that this could work, and this led to this pivotal trial called the Eliana Trial, which enrolled 75 patients up to age 25, so kids and young adults with relapsed refractory ALL, and again, confirmed this complete remission rate of about 80%. And even though some of these patients did unfortunately go on to relapse later, 60% of them were still in remission 12 months after getting this one-time treatment. And they found CAR T cells persisting up to 20 months in these patients. And so this really led to the first gene-modified cellular therapy to be approved by the FDA. And this is called Tisagen Lec-Lucel, or Kymriah, and this is the one that was actually developed at Penn that you saw in that. And this was just the celebration at our center when the approval occurred on August of 2017. And so this is now available on the market to treat patients up to the age of 25, and there are ongoing trials in older adults as well, showing that it is active in that population and hopefully get approved for a wider group of patients going forward. The other disease where CAR T cells have been approved and showing a lot of promise is called diffuse large B-cell lymphoma. This is an aggressive form of non-Hodgkin's lymphoma. It's the most common type of non-Hodgkin's lymphoma, and it also is curable with a combination of antibody and chemotherapy called R-CHOP, and about 60% of patients can be cured. However, for those who are not responding initially to R-CHOP or respond and the disease comes back, we try other things like stem cell transplant and other chemotherapies, but many patients unfortunately become resistant to all of these. And so this also expresses CD19 and could be a target for these CAR T cells. And so actually now, after some initial small studies, there have been 3 larger studies demonstrating activity of CD19 CAR T cells. The ZUMA trial enrolled 100 patients with very refractory large cell lymphoma with an 80% overall response rate, 60% in complete remission. And again, some of these patients relapsed, but about 40% of these patients without other options were still in ongoing remission over 2 years later. And this led to the approval of another CD19 CAR product that's called AxiCab or Yescarta. The Juliet trial was similar and got an approval for Kymriah, the other CD19 CAR product, and there's a third product that also has shown very similar activity in refractory large cell lymphoma patients and may be on the market soon. There also is activity in other types of B-cell non-Hodgkin's lymphoma, follicular lymphoma, mantle cell lymphoma, and those trials are ongoing as well. And so yet another cancer where this was effective. And then the third disease where there's a lot of promise, and this is the one that I focus on and treat, is called multiple myeloma. And this is another cancer of the bone marrow. It's caused by different type of cells called plasma cells that become malignant, and this can lead to calcium level elevation, kidney disease, anemia, and unfortunately bone disease that can lead to painful fractures. And multiple myeloma has a number of treatment options, and treatment has been getting better and better for the past 2 decades. But unfortunately, eventually patients do become resistant to all the available therapies, and then options are once again limited. And the problem with developing a CAR for myeloma is that myeloma does not express that CD19 where all the other cancers previously I spoke about did. And so we had to develop or find a new target. And the one that's emerging as the best target that you'll be hearing about in myeloma is called BCMA, or B-cell maturation antigen. It's expressed on normal plasma cells, but also on the malignant myeloma cells in almost every patient. It also can circulate in the patient's serum, so you can measure it and as a means to see if patients are expressing it. And importantly, it promotes myeloma growth and survival, so it's an important receptor on the myeloma surface, and therefore a good target for CAR therapy. It's not expressed on other cells of the body, so we're not expecting to have toxicity when we target it. And there actually are multiple approaches going after BCMA, not just CAR T cells, but antibodies and other things as well in the clinic. But in terms of CAR T cells, there were 4 initial trials that looked at BCMA CAR T cells in highly refractory myeloma patients. The initial 2 studies at the National Cancer Institute and our center a larger multi-center study from a company called Bluebird, and then a study in China. And these used different types of CARs. They had different patient populations in terms of how many prior treatments they'd had. But the bottom line was, again, in this highly refractory group of patients, responses anywhere from 64 to 96% of patients got their myeloma levels down after an infusion of these CAR T cells, including many with deep remissions. And so this has led to multiple ongoing BCMA CAR T cell trials in multiple myeloma right now, with several registration trials that are completed accrual, and we hope will lead to FDA approval in 2020 for this, and we'll have a CAR T cell for myeloma. We do see some durable remissions in multiple myeloma with CAR T cell therapy, a few patients where the disease has stayed away for 2 or 3 years, but there seems to be a difference in myeloma compared to ALL and lymphoma, where even patients in complete remission for a year or 2 can still have the disease come back after CAR T cells. And so I think we have more work to do in myeloma. This is likely not a cure by itself, at least in the late stage where we're giving it at this time. And I think that's why there's a lot of research going on to see how we can improve it. But again, this really provides another option and some hope for these patients. And so to talk about the side effects and toxicities for a moment of CAR T cells, these are very different than the typical toxicities you think of with chemotherapy. As we heard about, you don't lose your hair or have vomiting or mouth sores or this type of thing. But there are some unique toxicities that can be seen. There's a theoretical risk whenever you insert a new gene to a cell that you could insert it in the wrong place and cause the T cell to become malignant itself. Fortunately, that has not been seen in any of the CAR trials, but there's long-term follow-up up to 15 years for all the patients in these trials to make sure that doesn't happen. Depending on the target, for instance, CD19 is on normal B cells, so you may decrease your own body ability to make good antibodies, and so many of these patients have to get antibody replacement called immune globulin or IVIG, and that prevents it. But the 2 main side effects have been cytokine release syndrome and neurologic toxicity. And what happens with this is when CAR T cells get activated, they release factors in the bloodstream called cytokines. These are molecules that help to signal between the different immune cells and activate the immune system. And they're responsible for some of the symptoms of an infection, like high fever and muscle aches and things like this. When the CAR T cells sometimes get activated, they all get activated at once and can release a storm of these cytokines into the blood. And this can actually mimic a very bad flu infection. You can have high fevers, muscle aches, fatigue, loss of appetite, and patients can feel sick. This usually happens within the first week. And typically, if it's not that severe, we just support the patient, we admit them to the hospital, we give them IV fluids and Tylenol and medicine to help them, and this gets better. But this can become severe, and in some cases, it mimics more of a sepsis-like syndrome with low blood pressure or difficulty breathing. And so this does require treatment in a center that has expertise in managing these patients with intensive care units available if necessary. But fortunately, we're able now to anticipate this and manage this in the majority of patients to allow this to become still a viable treatment. And in addition, some patients can develop what's called neurologic toxicity, and this can be anything from a mild confusion in the setting of high fevers, but in rare cases, more severe delirium or even seizures or coma. And again, this was more of an issue when these cells were first being used 5, 6 years ago, and we weren't recognizing this, and fortunately, we now are able to intervene to try to limit this from becoming quite as severe. And in fact, what we use is sort of an antidote to one of those cytokines called IL-6, which is highly released in CAR T cells in cytokine release syndrome. And there happened to be a medicine that was already available called tocilizumab that blocks this IL-6. And if you give this tocilizumab, it almost acts like an antidote for the cytokine release syndrome. The fevers rapidly come down, blood pressure stabilizes, patients feel better. And so this fortunately does not appear to harm the CAR T cells or keep them from expanding and still killing the tumor. And so we've been able to incorporate this into our treatment protocols now. And there even are studies going on seeing if we can give this very early as a preventive medicine to see if we can even prevent patients from getting sick from the cytokine release syndrome. And so this has allowed this to become, again, a more manageable toxicity. And so CAR T cells, I think, are clearly showing a lot of promise. And as I mentioned, there already are 2 products that are FDA approved and on the market. But there still are a lot of issues we need to work out. I think we're really in the infancy of CAR T cell therapy, and I think that it will continue to be refined and improved over the years. But some of the issues you can see here, So one problem is that it takes almost 3 to 4 weeks to make the CAR T cells and get them back to the patients. And some of these patients, unfortunately, have very aggressive disease, and the cancer gets worse while they're waiting for the CAR T cells, and they're never able to get the CARs. And this is a small subset of patients, but is still an issue. And so there are now efforts to try to shorten the manufacturing process. Scientists at our center have gotten it down to 4 to 5 days even. And also these efforts to develop what are called off-the-shelf CAR T cells. Instead of getting them from the patient, can we just have healthy donors give T cells and make the CARs ahead of time so they're just waiting to go so they could be infused into the patient. They may not stick around as long as the CARs from the patient themselves, but it could maybe be a bridge while you're manufacturing your own CAR T cells to hold the disease in check. Another problem that we've noticed is that the cancer cells, unfortunately, still can sometimes outsmart the CAR T cells and lose the target. So leukemia patients have lost CD19 after getting CD19 CAR T cells. And so there are now efforts to try to get CARs that target 2 different antigens. And this is being looked at for leukemia and myeloma as well. And maybe you'll be able to prevent that escape. Some patients, unfortunately, because of too much prior chemotherapy, perhaps, their T cells are not functional, they don't make a good CAR product, and so you infuse the cells and they just don't expand or they don't last very long. And so there are a lot of efforts to try to make healthier or better CAR T cell products. Maybe we should start earlier and not wait until patients have exhausted all of their treatments, but do it maybe when they're first diagnosed and the T cells may be more healthy. And there are new manufacturing techniques and other combinations that are trying to, again, overcome this limitation. There are efforts to make safer CAR T cell products with safety switches or suicide genes, so you can give a drug and turn off the CAR T cells quickly if the patient starts to get sick. And then another big issue that in the CAR T cell field is that almost all of the efficacy has been seen in the blood cancer so far, in bone marrow, and in solid tumors like breast cancer and prostate cancer and lung cancer, the CAR T cells have not worked as well. And so there are a lot of efforts to try to identify better targets in solid tumors and to try to come up with CAR T cells that can overcome the immune suppression within the solid tumor environment to see if they'll work. And then finally, I think there still are a lot of logistical issues with CAR T cells getting them to patients all over the world. And so most of these trials, unfortunately, have been conducted so far in North America, in Europe, in Asia. I actually was unable to find any CAR T cell trials that had been conducted in Brazil up to date, although I'm aware of some that are going to be starting. But there needs to be more advocacy, I think, from hospitals and patient organizations and doctors to encourage companies to open these trials in other centers around the world, train those facilities and physicians and nurses to learn how to take care of CAR T cell patients, and then we'll be able to get this to more people. And then finally, the cost is going to become an issue. All cancer therapy is expensive, but CAR T cell therapy is very expensive. It's a one-time treatment, and so the cost for some of these is very prohibitive in any country. And so I think this is an area that really needs to be explored more. The hope is that as more companies develop these, the increased competition may drive the price down somewhat, but I think that remains to be seen. And so I think to conclude, the real take-home points now, I've explained what CAR T cell therapy is. It's an infusion of T cells that are genetically modified to recognize a surface on the target of the cancer cell. And this has been shown to be effective at targeting several different hematologic or blood and bone marrow cancers with high response rates in ALL, diffuse large B-cell lymphoma, CLL, I didn't have time to show that data, and also multiple myeloma. The durability of response has been more variable, however, and some patients will get an initial response and then lose it. And I think we need to understand better how tumor cells become resistant to CARs, and they will be able to overcome that. The toxicities are cytokine release syndrome and neurotoxicity. These typically occur within the first week or two and then are managed, and we have not generally seen late or long-term toxicities. And finally, it's important to stress this is still early in development. These are early times, they're very exciting, but I think these are the first generation CAR T cells, and we're only going to get better at this as we go along. And so I really do believe the future is very bright for this therapy, and hopefully it'll be able to be used for more and more patients going forward. And just to give a follow-up on the little girl who you saw in the video, this is Emily Whitehead. She's now 14 years old. She's been 7 years without any sign of her leukemia coming back. And she's actually, her parents and her have started a foundation trying to raise money and awareness for CAR T cell and other B-cell therapy for B-cell cancers. And so I've put that website there for you. And thank you very much for your attention.